Hello everyone. It's my privilege to introduce Dr. Priti Desai, India's first child life specialist. Dr. Priti Desai is an associate professor at East Carolina University in Greenville, North Carolina, where she teaches child life, child development, and diversity courses in the Human Development and Family Science Department. Prior to teaching, she has worked as a child life specialist at the Children's Healthcare for Atlanta, Johns Hopkins Children's Center, and at the Kennedy Krieger Institute in Baltimore, where she worked directly with hospitalized children and their families to promote their adjustment and coping with illness and healthcare experiences. In India, she worked for Chetna, a health education organization addressing the needs of children, women, and families in rural, tribal, and urban slum areas. Her academic credentials include a doctorate in human development and family studies and masters in child development from MS University of Baroda, India. Masters in Public Health from Emory University, USA. Dr. Priti has conducted numerous presentations and workshops around the world and serves as a volunteer, leader, and educator with organizations including Operation Smile as well as the KG Patel Children's Hospital and Can Kids Camp in India. Dr. Priti has served on 12 Operation Smile missions around the world and has served on several education programs to develop awareness and capacity building for psychological needs of children with health concerns. She initiated and directs a camp for children with complex heart defects in eastern North Carolina. Dr. Preeti's published work includes research and review articles in peer-reviewed journals as well as textbook chapters. She has received many awards throughout her career, including Child Life's highest professional honor, the Distinguished Service Award in 2013. We feel honored to have you with us today for this international virtual conference on interdisciplinary scope of human development. Over to you, ma'am.
Hello, good morning, everyone. I'm very honored to be here, and it's a tall task to follow the very engrossing and thoughtful presentation by Dr. Shagufa Kapadia, who's also my mentor. I'm very excited to be here, really, just to be among scholars and students all over India. So thank you so much. So let me see if I can just share my presentation and then we'll get started. Thank you. Can you see this?
Yes, we can.
Okay, wonderful.
Yeah.
Okay, great. So the focus of my talk will be with reference to children who are experiencing the need for healthcare services as one aspect of human development. Here you see a child who has a very complex cleft lip and cleft palate, and he's just happy and just as children should be. We're gonna spend about 45 minutes talking about these children and their families. A brief agenda, and I'm going to have to talk really fast to cover all of this. So we'll talk just a little bit about who these children are, what is child life, what are the core interventions for child life, the 4 core Ps, just a quick thought on the assessment of children's vulnerability to stress, specific to healthcare settings, impact of illness on children in different age groups, the rights of children in healthcare, a brief history of child life work in India, as well as a call to action, and hopefully have some time for questions and discussion. First, before I start, I just wish to express my gratitude to Dr. Sister Aparna for welcoming me, Dr. Sujata Kedar Gupta. Again, I am very grateful for this opportunity to present this work to the wonderful audience all over India. My alma mater, the Maharaja Syarchira University of Baroda, I get very emotional when I speak about everything I've learned here from Dr. Moite, Dr. Kapadia, Jigisha. So I just want to say this at the outset. My childhood schooling was Mount Carmel Convent School in Ahmedabad. So I am very much a Carmelite, and I'm very proud of that. I'm very grateful for all my career opportunities for all the children's hospitals that I worked in at my current university, East Carolina. My family, they are the roots. And also, like Khalil Gibran said, you know, they just shot the arrow, you shoot the arrow out. Some very supportive parents, grandparents, sister, brother. And I think we always need to remember who helped us get to where we are. And last but not the least, the precious children and families that I have been privileged to work with. So at the outset, I want to express my gratitude. So jumping into the topic, looking at just human development basics, we all know that human development is shaped by an ongoing interplay among the sources of vulnerability and the sources of resilience. And in my context, I'm going to speak to the vulnerability with reference to chronic healthcare needs or any healthcare needs. And just knowing that the course of development can be altered in early childhood by effective interventions that change the balance between the risk that is presented and the protection, the buffers that we provide to the children, and thereby we're shifting the odds in favor of a more adaptive outcome for children. So let's just take a quick look. What kind of illnesses are we talking about in children? So the illnesses can be congenital or acquired. So children could be born with really complex heart defects, cleft lip and palate, other conditions, or they can acquire illnesses in the process of growing up. So it could be as early as in infancy all the way through adolescence, or even as emerging adults. So they can acquire diseases like cancer, diabetes. So there's just countless illnesses that they can acquire. Illnesses can be infectious or communicable or non-communicable kind, so non-infectious. They can be acute. The healthcare needs can be very acute, like having an appendix removed, or something that is very chronic, that is going to go on for a period of 3 months or longer, or for the lifetime. The management of this might need to be ongoing. And there is the potential for premature death in these children. Chronic conditions, we need to look at 3 kinds of chronic conditions. And so we don't mix these 3 up. There could be overlaps, but they're separate. So chronic conditions can be illnesses such as cancers, diabetes, asthma. Chronic developmental conditions are those like cerebral palsy, autism, attention deficit disorder. So that's different than having an illness. So a child with cerebral palsy might also need surgery, but they're not going to be admitted in the hospital just by the virtue of the fact that they have cerebral palsy or autism. The third chronic condition is mental health conditions. So these are depression, personality disorders. So again, you can see that these are separate, but there could be overlapping conditions. Again, when we look at illnesses in children in the childhood period, we also need to look at the age spectrum, because there's a bidirectional impact of having an illness on the child's development and the child's development stage on how they are going to cope with that illness. So we need to be mindful of that. And Of course, when we talk about childhood illnesses, there is the underlying need for interdisciplinary work, which is the focus of this conference. So obviously, as you work with children in healthcare settings, you're going to work with doctors, nurses, social workers, psychologists, nutritionists, dietitians. We work with numerous providers for the well-being of the child and the family. So again, why do children have to go to clinics and hospitals? So of course, it starts with the routine pediatric care visits, where children have to go for immunizations and common childhood healthcare needs, the coughs, the colds, the tummy aches. Then children might need have to go to the and end up in the emergency room a lot, needing emergency procedures for seizures or convulsions, respiratory distress, loss of consciousness for various reasons, severe vomiting, diarrhea, dehydration, trauma, burns, drowning, foreign body aspiration or ingestion. Children, this is very common with toxic ingestion in toddlers, particularly as they're learning to explore and open bottle lids and mistake fluids that might be stored in different containers for something they can drink, and then they drink these cleaning liquids, and they could burn their esophagus and might end up in a medical emergency that could even be life-threatening. Other surgical emergencies, and of course child abuse related cases where children who have sadly become victims of severe beating or burns or any of those, and they end up in the hospitals. And there are many, many, many more reasons why children might need to go to the hospitals. So again, very much part of our day-to-day life of children. So when children end up in hospitals, there are several stressors that they face. First and foremost, especially young children, they fear being separated from their parents. They need their parents near them, especially when there is stressful situations going on. Then children are in very unfamiliar surroundings in a healthcare situation that is very distressing to them. Fear of not knowing what is ahead is also very distressing. On the contrary, we often believe that, and mistakenly so, that children will be afraid when we tell them what will happen. It's really the otherwise. It's often children's imagination that are taken over by what might be the reality of their experience. Another stressor is just the actual physical discomfort from the diagnosis, so the pain that might happen as a result of the illness, or the actual physical discomfort from the procedure. Losing a sense of autonomy and control, invasion of privacy. This, again, is important to children of all ages, but particularly children of school age and adolescents. And the fear of bodily mutilation. So for young children, when the doctor or the nurse takes a blood sample and they insert the needle in their vein and remove the needle, for a concrete thinking child, there's just a hole that has been punctured into their skin. And in their imagination, the blood could be rushing out. So they're very relieved when there is a Band-Aid put. So that's physically stopping the blood. So this is how there are many misconceptions. So there are many different fears of bodily mutilation for different children in different age groups. So again, we see negative reactions to the stress of hospitalization. So you might see children hitting, biting, biting in response to the fear that they feel. So it's the neuroscience of behavior, the fight, flight response, or sometimes they give in, which is the passive response. And then often you might see regressive responses where children go back to an earlier stage of development to cope with the stress of being in the hospital. So just quickly introducing to you right now the role of a child life specialist. So what do child life specialists do? So that's me during much younger days in a playroom that I had the privilege to help design with infants and toddlers with cardiac heart defects. So the role is to provide emotional support, provide therapeutic play, preparing children for medical procedures, enhancing the hospital environment for normalization. So bringing things like toys, drawing, art, parents, schoolwork back into the hospital. This is what children understand and relate to, and to advocate for children and parents' needs overall. So child life specialists, using play and other forms of communication, a child life specialist applies an understanding of normal growth and development to respond to each patient on an appropriate developmental level in order to enhance the child and family's ability to cope while minimizing the stress that is associated with that specific healthcare experience for the child. So that's just an overview. Research has shown the benefits of child life services to be as follows: less emotional distress for the child and the family, more effective coping during the medical procedures, better understanding of hospitalization for both the child and the family, quicker recovery and earlier discharge. So research has actually shown the physiological benefits of receiving preparation at stress points, lowered blood pressure, earlier opportunity to pee or urinate after surgery, which is an important indicator that doctors look for. So those kinds of physiological indicators, research has also shown that child life services help with that. The whole work environment is more positive and more productive. And obviously there's going to be positive public relations value for the hospital. And you will see more why when I continue this presentation. So how does a child life specialist spend a day in the hospital? So the child life specialist will be assigned to different units if they are working in a large children's hospital with multiple specialty units, so cardiology, neurology, oncology, general pediatric surgery. So a child life specialist will start their day by talking with, printing out the census report and talking with the nurse, the charge nurse, or the individual patient nurses, and get a report on the children that they will be interacting with in that day. Then they will go around greeting children and families. Another big part would be planning a group play or individualized play interventions, providing psychological preparation, teaching about children's diagnosis or procedures, team meetings and communications with the interdisciplinary team members. And then it's impossible for one child life specialist who might have a workload of 30 to 45 patients in a day to do so effectively without working with students and volunteers. So they will essentially work with students and volunteers. I have a brief 1-minute video clip in order to show you just how one child life specialist works. So let me try. Let me see if it'll work. So please, let me see. And if it doesn't work, I will pick up.
In the emergency.
Sorry. I'm sorry, that I'm sorry that there was a lot of videos that opened all at once, so I'm sorry I couldn't show that to you very clearly, but it was showing a child life specialist in action working with the child. But hopefully I'll have lots of pictures that you can see that'll help you get a better idea. So the mission, vision, values for child life is to be able to work with infants, children, youth, and families, play, therapeutic relationships, developing therapeutic relationships with the children, families, as well as the interdisciplinary staff, communication, effective communication, having theoretical foundations of practice, professional collaboration, standards of practice, and research. The theoretical foundations for child life work really look at play as a healing modality, cognitive theories, attachment theories, psychosocial development, temperament theory, very, very important, systems theories, and then the stress coping theories are all the foundation of our work. So we look at, from the psychological stress, we look at the event or the stimulus for the child. So if the event is having an appendix removed, an appendix surgery, then the child will appraise this as, oh, I can deal with this, or no, this is going to harm me. And then they will have a response. And this is the response that we will assess and provide education to the child and family to cope with this kind of response. Again, we look at children with all different age groups. So here's a question for you to quickly think about. Which age group of children do you think finds hospitalization most difficult and why? A, babies less than 8 months, B, between 8 months to 4 to 5 years, 6 to 12-year-old children, or 13 to 18-year-old children. And in the interest of time, I would go on to answer the question, but just think for yourself which one you picked. So the correct answer is B, that children, older infants through young preschool age children are considered the most vulnerable to feel the negative impact of illness and healthcare, primarily because their separation anxiety is high and their stranger anxiety can be high as well. And it is very difficult to explain to them the different aspects of when parents are coming back, what is happening to them, what is going to hurt, what is not going to hurt. So it's just a difficult time for them. And in particular, children see many providers in the hospital. And so they don't know who to trust or not trust from their perspective. So if you look at infants, we all know from Erickson's point of view that the baby is developing a sense of trust or mistrust. In order to develop trust, what elements of care are important for the baby? Comfort, food, touch, quiet environment, and sleep. In contrast, take a look at this infant in a neonatal ICU. As you can see, all the elements that a baby will need are not going to be present in this baby's life in the NICU. And hence, they are going to be leaning towards the continuum of mistrust. They have painful stimuli, they have lack of parents, their feeding is through a tube, and so they just do not have those normal child development experiences as infants. Again, when we look at child development and the impact of illness, we look at typical milestones in all domains of development, identify stressors in each domain, and then look at what might be the different age-specific interventions. So I'm not going to read all of this in the interest of time, because again, we could have, whole lectures on this, on just each age group of children. But again, it's just to show you that we consider those differences. When we look at the stress potential assessment, we look at 3 variables: the healthcare variables, the family variables, as well as the child variables. And we look at the interaction between all of these 3 in order to decide which child is going to feel more stressed or less stressed, and therefore plan our interventions accordingly. So for example, for healthcare, is this a new diagnosis of cancer? What are the anticipated treatments? What is the prognosis? Is the child likely to get well? How long will they need these medical procedures? So looking at that, or is this child dealing with this cancer for a couple of years and they're familiar with the staff, they're familiar with the treatment? Doesn't mean they still don't have a difficult time coping, but their familiarity will change. Family variables. Is the family present? Are both parents available, or is the family having to travel hundreds of miles to get to the biggest hospital system? And so one parent is home and the father or the mother is with the child, but the other parent is not available. What do the parents understand about the procedure? What are the cultural variables here underlying how they cope? What are their beliefs about medical treatment versus more indigenous aspects of treatment? And then, of course, the child variables are very, very important. So let me talk about the 4 Ps of the core child life interventions. So if you forget everything I have said, if this is something you can remember, that might be a good way to think about, okay, what did I hear today about child life? The 4 Ps: play, psychological preparation, pain and anxiety management, and parent empowerment and family-centered care. And I will explain each one briefly. So play and therapeutic activities. Play for children in hospitals provides them a sense of normalization. So there's an analogy. If you are traveling to another country and everyone is speaking a language that you do not understand, and then you find someone who speaks your language, just imagine the joy and sense of relief, like, oh, someone is talking my a language that I can understand. Play does the same thing for children in hospitals. It's the language that they understand in this unfamiliar world of healthcare. So it provides a sense of normalization, helps them gain mastery. It gives them a sense of expression and increasing the sense of psychological safety. When children are going to be hospitalized for extended periods of time or repeatedly because of their chronic condition, play provides them the opportunities for physical, social, intellectual, emotional development, and being able to use a playroom space gives them an escape from the distressing reality. Children need play for various reasons. And again, there's a difference between play therapy and therapeutic play. So child life specialists provide therapeutic play, not play therapy, because that requires different licensing. So there are various reasons children would benefit from both kinds of play, but I'm just speaking on illness and hospitalization. This is very important. Play has an important role in prevention of psychological trauma, thus making more curative interventions less necessary. And I would like to mention to you the purpose of one specific type of play in hospitals, which is called medical play, in which we use dolls or stuffed animals or other objects to allow children to practice, explore the kinds of medical treatments that they might be experiencing themselves on the doll. With supervision, they can also use needles. So you can see this child is accessing what we call a port, which is an IV kind of an intravenous line, but the access is in the heart. And the child will have their own, and the child is playing with the child life specialist to clean and access this. And this is typically inserted in a child when they have cancer and they're going to need medicines for an extended period of time. They can also access blood from these. This way, it prevents a child from having to be stuck with a needle very, very frequently. So with medical play, you can provide, clarify misconceptions, provide a sense of control and mastery, and just educating the child about the materials that are being used with them, and it definitely helps reduce their anxiety. Here's something we can all do. We all, as human development specialists, know how to play with children. So we can play with children in hospitals with appropriate training and supervision. And definitely in hospitals, we need to be mindful of toy safety, infection control. We do not use stuffed or cloth toys in hospitals. because of infection control reasons. And there's various types of toys, doctor play sets, indigenous toys. I know is a big push for indigenous toys in our country currently. So they can be used, but again, we have to be very mindful of different cleaning procedures so that we don't introduce new infection for the children as a result of the toys that we use. Psychological preparation and coping. That's the second P. What is this? This is communicating accurate, individualized, developmentally appropriate information in advance of the experience. The information we provide to the child are reasons for a threatening or painful procedure. Why are they having to have the MRI or the CT scan or just getting a blood test? What are the anticipated sequence of events? What's going to happen first and next and next? What are the sensations that accompany these experiences? And then coping, education, and rehearsal. So a quick example, I've worked with children with heart defects a lot. So if a child was going to have an open heart surgery, one of the things that would happen for them is they will have a intubation. So they will have a tube inserted into their mouth and their throat in order to help them breathe while they are being operated, while the bypass bypass procedure is going on. So one thing, this is just one small aspect of teaching a child about one small aspect about their heart surgery and when they wake up from it. So if a child has the tube, the endotracheal tube in their throat when they wake up, when they try to talk or call out to their parent, their voice is going to come out like this in a whisper. And so we prepare the child for it and we practice that. So it's important that the child has practiced this. So when they wake up and they're sedated, they're afraid, they're in pain, they're surrounded by equipment. And then when they try to talk, their voice doesn't come out. The nurses has to remind them, remember, it's okay. You have a tube in your mouth that's helping you breathe. That's why your voice is in a whisper. And that immediately helps reassure their child and they will be less anxious in the moment. So here, how do we as human development specialists learn about these different medical diagnoses? So that is very much part of our education. So I'm very proud to share these pictures from a summer institute I did at Baroda at my alma mater. So here are students learning about Guillain-Barré syndrome. And trust me, they did their own research, which is researching the symptoms, what are the risk factors, what are treatments, and then how do you talk about all of this to children, which is very much part of our job. So the key elements of communicating complete and accurate information to children is first, as child development, child life specialists, we have to learn about the procedure. So if you look at Guillain-Barré, one of the things is plasma exchange and immunoglobulin therapy. So plasma exchange, what is that? So we need to learn about this. So it's like dialysis in plasma exchange, different aspects of the liquid content within our blood that has become sick or not well. So I'm speaking like I would speak to a child, has to be cleaned and filtered, and the newer, more healthier blood needs to be reintroduced, right? So again, we need to learn about the procedure. We need to decide what information to share, provide the sensory information, the sequence, explain how long the procedure will take, and then monitor the accuracy of the information. So what did the child really understand? So what is the purpose of preparation? Assessing the child's understanding. What do they think is going to happen? So quick example, I had a child who was going to have a hole closed in the top chamber of her atrium. Somehow the father, in all his, I guess, not understanding what he was doing, had told the child that this was a 9-year-old child, that he had told the child that the doctors were going to remove her heart and put a boy's heart in her body. So now the child is thinking they're going to take my heart out and put a new heart in me, when clearly the only thing that was going to happen was closing a small hole in the top chamber of the heart. So it's very important to understand what the child thinks is going to happen so that we can increase the accuracy of their expectation, thereby reducing uncertainty, fear, and anxiety, imparting accurate information so that we can facilitate effective coping behaviors, and above all, establishing trusting relationships with all hospital staff. We use very creative materials with children when we prepare them for surgeries. We use dolls, we use photographs, we use picture albums, human body puppets, actual medical equipment, information sheets, check sheets, videos, computer-based programs, discussions, and hospital tours when those are allowed. So here's an example of a makeshift. You can guess this could be a pretend made out of cardboard box, creatively, an MRI machine. And here's my colleague teaching about using the models with the children, using the picture books to teach children about what to expect during the MRI procedure. How this bed would be slid into a big hole, nothing touches them, but they're going, if you're claustrophobic, this can be very scary. And the MRI machine makes very loud knocking noises. Again, often children are awake during these procedures, and they can take up to 30 minutes, which can be a very long time for the procedure. So again, it's very important to explain these things to children. Procedural support, we are very much present with the children during the procedure and provide them with pain management. So it is very common to hear children screaming and crying, especially if their temperament is of that nature. You do have very many children who calmly engage with medical procedures. But this is the third P. We're very much part of the non-pharmacological pain and anxiety management, part of the treatment team. The doctors definitely prescribe the pain medications. Again, these are very important to work collaboratively. But the gate control theory says that pain impulses are moderated by a gating mechanism. And so if we use distraction, suggestion, relaxation, breathing, imagery, they do help prevent sensory transmission of pain. So we're come from the country that introduced yoga and meditation to the world. Again, these are increasingly being used with children in hospitals, breathing techniques, play, drawing, all of these are very much integrated with as part of children's pain management. Pain is very important to control in children. Dr. Leora Kuttner is a psychologist in Canada, and she has done very extensive research and work into children's coping with pain. There are some myths and false beliefs about children and pain, such as children do not feel as much pain as adults, children will get used to it, opioid analgesics are dangerous and can cause addiction, so these are some myths. Children have reduced opportunities to make decisions in the hospitals. So many things are just being done to them, and they don't really have a choice. In contrast, when we, human development professionals, offer them normal things like arts, crafts, play, back to them in the hospital, it just gives them a sense of control. So when I'm working with a child in the hospital who has a lot of stress and pain and no control over a lot of things happening to them and to their bodies, I'm very intentional. So even if we are coloring with them, I make a big deal. Do you want to use a red crayon or a blue crayon? What would you like to do with this painting? And give them that sense of, yeah, I can still choose, I can still control things. So again, the intentionality of our language to make the child feel more active is very important. Emotions. It's very important to allow children to cry, express their anger, fear in the hospitals. And often they don't have the words to express their feelings, especially when they are younger. So they can do that through arts, play, throwing, anger kinds of activities. So this is very, very important. For teenagers, the creative process facilitates a more honest reflection about living with diabetes or cancer or a seizure disorder, and allows them to express their feelings, their hopes and dreams to live a more normal life. Here's a little picture from the video that you could not see very clearly. Again, the child life specialist is using a fun toy with a child to distract them through a light and colorful sound making toys while the nurse is doing a procedure for the child. And another parent or another child life specialist is holding the child in a comfort position. And again, this is allowing the child to cope with the medical procedure. Positions for comfort is another technique. When you lay a child down flat on the treatment table, laying supine, research has shown, creates more fears and misconceptions. So if you can sit the child in the parent's lap, this can be a more effective coping technique. But some children like to see what is going on, and some children do not like to see what is going on. So these are coping sensitizers, and these are deniers or minimizers. So for this child, if you try to put them in this position, they will not cope very well. So again, there are differences. Again, this you have to work with the interdisciplinary team to incorporate, and these kind of changes might often give us some pushback. Another P, the last P, is parent empowerment and family-centered care. We need to treat every parent and family member with dignity and respect. They need to understand completely what is happening with the child. Again, often our doctors and nurses with the large patient volumes do not have the time, and often may not take the time to explain what is happening with the child in the healthcare. And so child development specialists as part of this team can provide this information, of course, with appropriate training. Again, culturally responsive care is very, very important. Parents, when they learn about their child's diagnosis, go through shock, denial, anger, bargaining, grief, acceptance, and eventually accommodation. So this is not a linear process. Different emotions surface, and as child life specialists, we have to be able to work with these children and their parents in a respectful manner, and matching their emotion and validating their feelings. Parents feel guilty. What did I do wrong during my pregnancy? Why was my child born with a heart defect or with this gaping hole in their mouth? Lots of fears and misconceptions. Just like children, parents have them as well. They worry about the pain. They worry about long-term. Who's going to marry my child? Will she ever be able to give birth if they have, this condition? Who's going to take care of their needs? They worry about the finances. So parents have lots of emotional support needs, education training needs, and knowing where they can get access to community resources. Again, these are students from my alma mater in Vadodara at the Kashiba Hospital doing some parent workshops. Siblings, brothers and sisters of the sick children are very much part of the family system. They're often the ignored children. Here's a drawing of a 7-year-old sister of the baby brother who was going to have a heart surgery. And so she drew the little red dot to mark the heart, which should be on the other side or more towards the middle of the chest. But you can see how she's drawn the cot as inaccessible. And she explained this drawing as, they're going to remove my baby's heart, brother's heart, and then operate on it. So you can see that she's tethered the heart to the child's body. So again, very, very important. Other child life roles, quickly. Children often die in hospitals, and so we are very much part of the whole grief and bereavement process. Sometimes in preparing the child for death, the family, this is probably one of the hardest part of our jobs. Specialty camps. We have camps for children with different diagnoses. They have week-long camps or weekend camps. Child life specialists work in early intervention settings, child abuse settings, administrative responsibilities, and international opportunities to serve on medical missions. How could I not talk about child life during the pandemic, right? So usually child life specialists are in their normal street clothes. Instead, now child life specialists have to wear all the protective equipment, and they look just as frightening as other providers as perceived by children. And so playrooms have been shut down. More individualized bedside activities are happening with children. Unfortunately, in many hospitals, jobs have been lost as well. So how can we integrate child life in the healthcare? So we're bringing our knowledge of child development, communication skills, assessment, problem solving, collaborative advocacy skills. How do we learn to become child life specialists? A minimum of a bachelor's degree in child life, child human development, counseling, education, psychology, social work, required coursework, internship under a child life specialist, and then taking the certification exam. Of course, this can be modified for India, but we do need the core knowledge and training. Courses in child development, play, family systems, a course taught by certified child life specialists, death, dying, research, human anatomy, physiology, medical terminology, cultural competency in children with special needs are some of the courses. How can we do this in India a lot more? It's already happening. How can we increase this for all children? So again, quickly looking at the hidden child. The child might think that doctors looked at my stomach, my heart, my eyes, my ears, my mouth, but they never looked at me. So they feel invisible. How do we make them visible? So children, everybody in the community knows about the UNCRC and the idea of the non-discrimination, best interests of the child, the right to survival and development, and the views of the child. So I'm going to very quickly go through this. So children have the right to have their pain and suffering treated, that they should be viewed first as a child, then as a patient. We need to regard their individual abilities. They have the right to be afraid and to cry when they feel hurt. They need to be safe in the environment that they're unfamiliar with. They have a right to ask questions and receive answers that they can understand. They have the right to have familiar caregivers with them. They have the right for somebody to speak for them when they are not able to speak. And they have the right for their loved ones to be there, and they have the right for play and education, even when they're receiving healthcare. Because every child in the world has one thing in common, and their rights in the healthcare need to be uplifted, and their voices need to be heard. Here's another tool for us. The World Health Organization's definition of health is that the health is a state of complete physical, mental, and social well-being, and not just the absence of disease and infirmity. Therefore, what we as human development specialists can provide to this definition of health is very, very crucial. Quickly, historical perspectives of child life in India as I know it. My alma mater, my professor, Dr. Indira Malia, introduced me to child life. Dr. Jikisha Sastry has been a very prominent voice in uplifting this need for child life in hospitals, and has worked to bring this voice to healthcare providers, to pediatricians' offices. And Parminder Wadhwani is doing a lot of the work now. And I applaud our department for our partnership with Kashiba Hospital and other hospitals in Vadodara, and for doing innovative programming like providing a 2-week summer institute for child life, and just the young students who bravely set foot in healthcare. Kashiba Children's Hospital has a child development and child life program established there in 2011. Another great program is Can Kids, Kids Can, which is headquartered in New Delhi. They have a footprint in 99 hospitals around India in 22 states and 42 cities, and they are providing phenomenal psychosocial care for children in hospitals. These are children specifically with cancer. Operation Smile India, I'm a volunteer with them. They have conducted surgical programs in 24 cities since 2002. They have 12 permanent care centers in the country, and they are very welcoming of child life, and there are job opportunities with them. I have conducted child life workshops with CAN kids, you know, I've very much tried to be present in India. I am in India for at least 2.5 months every year. And so I firmly believe it is never too early to help a child in healthcare or in any setting. It might easily be too late. So with that thought, I end here and see what questions you might have for me. And I gave you my email address in case anybody has opportunities. There was one slide that I really wanted, but it didn't come up, which was the call for action. Just give me 1 second, please. It's this one. So I really want to take, let's see. There we go. There are a few thoughts that I would like to share with our August audience. One is the potential to develop highly specialized elective courses within the Human Development Family Studies programs in our universities, which is very much possible. Identifying faculty members to teach these courses. I know Dr. Sujata, Dr. Jigisha, Parminder, they're all very adept and interested in doing these kinds of initiatives. Parallel field placements for children in hospitals. So my alma mater is placing students for fieldwork rotations in Kashiba Hospital under supervision of Parminder. And it works beautifully and exposes young people to work with children in hospitals. Faculty exchange opportunities through Fulbright programs, very much possible for individuals to come to the United States or other countries. Student training opportunities. Of course, when we create a workforce, we need to identify hospitals within our country that might be willing to hire child development professionals in their settings. Identifying sources of funding, whether through NGOs, hospitals, private charities, or through the government. I understand that the government has positions for psychologists in children's wards for government hospitals. This needs to be tapped, and how human development professionals can be part of this system. Creating awareness among doctors and nurses about this need. Adopting a research agenda to do more indigenous research in India about children's coping with healthcare experiences, parents' feelings, parents coping, and creating that database in India, and then using virtual technology as we're doing right now to create this awareness. So again, I just wanted to share that. And just want to, when you look at the posters, I believe we have a poster with the more details about the partnership between MSU of Baroda, HDFS department, and Kashiba Hospital. So again, I will see what questions you have or comments. And again, I thank you very much for taking the time to hear me this morning. Appreciate it. Thank you.
Thank you, Dr. Priti, for enlightening us